Well, welcome everybody to the inaugural meeting of the UK Global Cancer Network. I think we all agree that this is a great opportunity for us to take, and if we can take this opportunity, it will make a huge impact in the years ahead. And I suppose by way of just introducing the week and certainly the UK Global Cancer Network, it's my pleasure to introduce a few words from Dame Kelly Palmer, the National Cancer Director for NHS England. Thank you.
Hello, I'm Kelly Palmer, National Cancer Director for NHS England and Improvement. It's my great pleasure to welcome you to London Global Cancer Week 2020. The aim of London Global Cancer Week is to really focus on improving survival in low to middle income countries so that we can make a difference to people experiencing cancer and the effects of cancer around the world, and together help to improve survival. I'm delighted that the UK has played a leading role in convening London Global Cancer Week this year. There are going to be 24 virtual events running from Sunday the 15th through to Friday the 20th of November, really focusing on action and practical steps to help improve support for people around the world. Thank you for joining. We have a number of organisations contributing, including WHO and the Commonwealth. It's a fantastic collaboration of people and teams to help us all make a difference. And I really look forward to hearing the outcomes of the week, and I'm sure it'll be inspiring, moving, and a really important week for all of us. Thank you.
Thank you very much. So by way of introductions, let's start by introducing the team who've really been the steering group of the UK Global Cancer Network. And first of all, just to introduce myself, I'm Richard Cowan. I'm a clinical oncologist at the Christie Hospital in Manchester, and I'm also the director of the Christie School of Oncology. And through our international school, I've been involved in international training in a variety of countries around the world, and more recently in projects in Kenya. And I'll now ask my colleagues, Susie Stanway, Annie Young, and Mark Lodge to introduce themselves.
Hello there, my name's Susie Stanway. I'm a consultant medical oncologist in the breast unit at the Royal Marsden Hospital with an associate honorary faculty position at the Institute of Cancer Research. I have interest in breast cancer, cancer survivorship, and a long-standing interest in cancer and global health. Over to Annie.
Hi, my name is Annie Young. I'm an oncology nurse by trade. I work at Warwick Medical School in the UK, and I work very part-time and focus now on international work. Thank you.
Hi, I'm Mark Lodge. I'm a consultant systematic reviewer and the executive director for the International Network for Cancer Treatment and Research, which has programs in low middle income countries in cancer registration, pathology, and childhood cancers. And I'm also one of the organisers of London Global Cancer Week. Richard?
Thanks very much, Mark. And maybe to introduce one of the more important people of today, the person at Mission Control, Corinne, who's probably got a few things to say to certainly help steer us through the virtual environment of this meeting. Corinne, thank you.
Thank you, Richard. My name is Corinne Nanton. I'm a virtual conference organizer. Just a few announcements, housekeeping announcements to help you understand how the session will work. The session is being recorded and it will be available on the London Global Cancer Week website shortly after the session. As attendees, your cameras will be off and your microphones will remain off for the duration of the session. However, if you have any questions, please use the chat box at the bottom of the screen, and from there your questions can be addressed. These will be addressed in the discussion sessions. Thank you.
Thanks very much, Corinne. So to just look at today's proceedings, the agenda for today. I hope you can see this on your screen, but I'll mention a few words about the network and then hand over to Susie, who will talk about the background. And then we've got great pleasure in having the international perspective to help guide us at this very important time in setting up the network, namely Richard Sullivan, Satish Gopal and Bhavna Sirohi. And each of those will share their experience for us. And then, as Corinne said, please put your questions and comments. We will ask for questions and comments to be taken at the end of the three talks, if you may, and Annie has very kindly agreed to sort of coordinate those questions. So may I now just hand over to Susie, who's just going to give us a little bit of the background.
So thank you all for coming again. So as way of background, in 2016, we held the first ever Cancer Control and Lower Middle Incomes Country meeting at the Royal Society of Medicine. For the first 3 years, this was an annual meeting until last year, where it became multiple events over the course of a week and was renamed London Global Cancer Week. And the aims of these annual meetings and what is now the week were really to convene those interested in global oncology, to encourage networking and the sharing of ideas, dissemination of knowledge and facts, to inspire others to get involved, and really to get this put on the political agenda in this country. So throughout the course of the last 5 years, there have been repeated calls, or a common theme has emerged, and that is that there's really a need to get a more structured, coordinated body of people that are interested in this in the UK. And that's really how this group has come about. Back to you, Richard.
Thank you very much, Susie. And so what do we mean by what do we mean by the UK Global Cancer Network? So I hope can you see this on your screen at the moment? Yeah. Is that right there, Mark? Great.
Yes, it's fine.
So after discussion, we're very grateful to our founder members, many of you who are here joining us today, for your input in trying to shape what we're trying to achieve as a UK Global Cancer Network. And I think it's worth at the beginning of the meeting just to share the mission statement that we have agreed, namely that the mission of the UK Global Cancer Network is to enhance the UK contribution to cancer care in low middle income countries by bringing together the talent, resources and enthusiasm of individuals and organisations within the UK in a more strategic and collaborative body, with the intention of improving the outcome and experience of patients at risk of living with cancer and their caregivers in lower middle income countries. So that sort of frames what we're trying to achieve today. And what would be the benefit of members joining just to get this underway, really? And the first thing is it will be the opportunity for collaboration. We recognise that many people in this meeting and elsewhere in the UK have made huge efforts and sharing their skill and expertise in different parts of the world in different projects. And I think this is an opportunity for us to collaborate more and bring that together. And also we recognise there are a lot of health professionals across the UK who would dearly love to be involved in projects in lower middle income countries, but haven't got the vehicle by which to get involved. And we see that bringing people together within this network will offer the opportunity for those people, and also for those of us who've got projects, suddenly our faculty can be expanded greatly by drawing upon members of the faculty. I mean, we will have the opportunity to grow international networks and contacts across lower middle income countries. And looking further ahead, there are opportunities for funding. And if, as a success, we can become a good coordinated group, we will be looking for funded projects under the umbrella of this network. And finally, there will be a newsletter. So that is the sort of what we're talking about today. And to really get us underway, we could do with the perspective from some people who know a lot about these things. And if we start with the UK perspective, I think there's no one really in the UK we'd recognise who knows much more about the global picture in cancer than our first speaker, Richard Sullivan. So it's a real pleasure to invite Richard to share his perspectives. Richard, thank you very much.
My pleasure, Richard. I mean, it seems we've got the dominance of the names.
Yeah.
So a real pleasure to be here. Welcome, ladies and gentlemen, as well. Thank you for asking me to make a few comments. I do have a few slides to share as well. I think hopefully you should be able to see that now on your screen. Let's double check.
Yeah.
How's that? Fantastic. So Richard and the team very kindly asked me to talk a little bit about the importance and potential of the UK GCN, and it really could not have come at a more important and opportune moment. I've got about 5 slides, and I'm going to start really just talking about the importance and basically the case for making UK's involvement in global cancer. Let me begin by a matter of principles here. We are a very wealthy country. We spend an enormous amount of on cancer research in the UK. By any metric, we're probably one of the best funded countries in the world, both for our cancer care and our cancer research. So there's this idea of global solidarity and fairness, that if we're spending this domestically, that of course, with a pluralistic, multi-ethnic society that we have in the UK, it's even more important to be seen to be working with partners across the world. And so it's this idea that Michael Marmon said that, you know, for fairer societies, you have healthier lives. And of course, cancer now, and I won't repeat the figures, is a huge global burden. The other issue that's come through, of course, and will get worse with the impact of the pandemic, is this idea of inequality as well. So the problem being around the world is a more unequal world. How do you deal with that? You have to put effort and time into bringing together people who are dedicated to making the world more equal, particularly when it comes to the health sector. Cancer, it's interesting because it is a huge development issue. We don't think of this disease as being a development issue per se. We think of child and maternal health, infectious diseases, but the reality is nearly every commission that's been done, and this one, for example, on cancer surgery, has showed the impact of cancer on the economic development in countries of LMICs. And we're talking the losses are between 0.5 and 2.5% of GDP, for example, if there is not upscaling of surgical services. And this is just one exemplar. This is replicated across radiotherapy and all other forms of care. So cancer is a critical development issue, and that is why the UK needs to be involved in this on a global stage. Also, the partnership in terms of looking at the UK GCN is also about supporting our partners and working with them around what are really unique and complex cancer transitions. Nowhere else in the world are they seeing cancer transitions in the way that we experience them in the West. In India, for example, the breathtaking movement of people across enormous distances to access care, for example, at Tata Memorial Centre in Mumbai, this is what these dots are. These are patients from all over India that move to Maharashtra, is utterly without precedent. And indeed, in countries that we don't even think of as having cancer problems, like Afghanistan, huge numbers of patients still are diagnosed every year, and they move vast distances, in this case, to access cancer care in Pakistan from Afghanistan. So we have very unique and complex transitions as well. The UK is embedded in the global health arena, and we're part of this. What about the potential? Well, I think the potential here from my perspective is really about better partnerships and also better commitment per se to global cancer. Richard has already mentioned this about the enormous talent that we have within universities, the National Health Service. We've got partners like the Lancet Oncology, for example, for years have been promoting global cancer through commissions and series. We've got loads and loads of funders as well in the UK. We've obviously got the traditional funders, the Medical Research Council, Cancer Research UK, but increasingly, of course, overseas official development assistance is being funneled through the Foreign and Commonwealth Development Office. So the opportunity here, I think, for the network as well is to leverage and to build these partnerships between the different researchers, be it for research or for capacity building. We also have another organisations. Susie's already mentioned the Commonwealth, Royal College of Surgeons, the British Association for Surgical Oncology, and the RCR, just to name a few, are all interested in the global picture. So we have a whole range of organisations involved in global cancer, which again is a great opportunity, I think, for the committee and for the network to bridge. And finally, of course, wonderful to have Dr. Satish Gopal with us today. We'll be talking in a minute after me about the NCI Centre for Global Health. But we have some great emerging networks around the world. In sub-Saharan Africa, Aortic, the National Cancer Grid of India, our partnerships at UICC, the IEA, and of course the World Health Organization. And so having a network in which we can actually build these sorts of relationships between the stakeholders, I think is a fantastic opportunity. And finally, this is, I think, one of the most critical things. I think it'll come up again and again throughout the week. I think it's fair to say by any metric, we're not spending enough on global cancer through any of the funders in the UK. And I think the network provides a great opportunity for actually leveraging the UK's funding position across multiple partners and leverage it in order to reverse this idea of knowledge subjugation. In other words, that at the moment, a lot of the Western conceptual models dominate the way we think about global cancer. But the reality is colleagues of mine from Malawi and Zambia, Grospec Parham and others have done remarkable research, which is locally and contextually relevant. And this is the sort of thing, really, I think that we're looking at in terms of developing this network, is building like-minded partnerships to really strengthen global cancer. And actually, as Callie Palmer was saying, improve outcomes. And I think that's crucial for the UK because we have been underpunching on the global scene, considering the amount of money we actually do put into cancer. And I leave the last word to the great James Baldwin, wrote in The Fire, next time, those who say it can't be done are usually interrupted by others doing it. There are lots of fantastic people, as Richard mentioned, around the UK, already engaged in multiple partnerships around the world. And so this is a fabulous opportunity to bring people together, to learn from each other and actually develop new partnerships, which transcend not just the cancer community, but I think the whole of the global health community in the UK. And thank you very much indeed, and I'll stop there.
Thank you very much, Richard. You know, you've highlighted the opportunity and the challenge. And as just to remind everyone, if you could put your questions in the chat box, and then we'll address them at the end of this session. So again, thank you very much, Richard, for setting the scene. So we also need to look further afield, and clearly one place where we do look for advantages across medicine and advances is the United States. And it's a real pleasure to invite Dr. Satish Gopal, who is the director of the Centre for Global Health at the NCI, to share a little bit of their experience, and perhaps we can learn from certain aspects of how things have been done over there. So Satish, thank you very much.
Great, thanks so much, Richard, for that introduction. And Richard Sullivan, I have to distinguish the Richards for your comments as well, which I think lead very nicely to what I was hoping to say today. So I want to just generally thank the London Global Cancer Week organizers for inviting me to participate this morning, and also for us as the NCI to host a session on Friday, the final day of London Global Cancer Week, which we're really thrilled to do. I don't have slides, but was going to kind of briefly summarize some of our experience at the NCI. I will touch on some of this in our session on Friday as well with slides, but I thought just a brief kind of preview of those remarks would be useful this morning. Just to introduce myself, I think Richard Sullivan already raised some of the important equity issues, and I do think it's sometimes important and useful just to acknowledge that the tenor of these types of conversations are often about on some level, even when we're talking about capacity building and equity, are really about how we in the global north are going to help others in the global south. I have a very different personal experience before coming to the NCI as the new director of the Center for Global Health in February of this year. All of my academic and professional life was really built in sub-Saharan Africa, where I took care of people in the public sector and led an applied global cancer research laboratory that included investigators across disciplines and at very different career stages, many of them very excitingly at very junior stages, particularly from the US and from Africa. And so I do often think it's useful and important at the beginning of talks like this to simply acknowledge that I really would not have a career if it were not for the generosity of many of the LMIC communities and collaborators that I've had the chance to work with. And of course, we are thinking about ways that we can continue to help this important field going forward. But I think it is without question that I have been helped a great deal by the opportunity to, again, work in some of the settings that we all have alluded to. So, to talk a little bit about the NCI now. So then the National Cancer Institute, as many of you know, is the largest funder of cancer research in the world. And it was sort of formulated in its current form by the National Cancer Act in 1971, which was signed into law by President Richard Nixon. So next year is actually the 50th anniversary of the National Cancer Act, which is something that we are very excited about at the NCI, and already have essentially a year-long communications plan together with many partners, including many partners in the UK and internationally, to commemorate the importance of that legislation in really driving, both creating the NCI as we know it, and also driving progress that has really made a difference in people's lives. As someone who's relatively new to the NCI, I have been participating in those 50th anniversary of the National Cancer Act commemoration discussions, and I've also revisited the original legislation, which actually includes an explicit global mandate for the NCI. And again, this is something I'll talk about briefly on Friday during our NCI hosted session. But I'm trying to remind people, both at the NCI, who sometimes don't recognize that the original legislation actually mandates that the NCI really be a global actor in some very specific ways. So, 40 years later in 2011, so the NCI has always been doing international work, but in 2011, I think this had reached a sort of critical mass that Harold Barmas, who was the NCI director at the time, felt the need to create a dedicated Center for Global Health. So we are actually turning 10 next year, which together with the 50th anniversary of the National Cancer Act. So that's very exciting for us. We are both trying to amplify some of the National Cancer Act 50th anniversary messaging with our international partners. We want to weave some of the really important global health contributions of the NCI into these 50th anniversary commemorations, and also use it as an opportunity to also celebrate the 10th anniversary of the Center for Global Health. And really the idea was to kind of elevate the importance of global health activities at the NCI and to coordinate them. And I guess I want to talk a little bit about what I think has been achieved sort of in the 9 years since, soon to be full decade. I do think that the creation of a dedicated Center for Global Health, although again, there was already global health activity going on at the NCI, sort of distributed across its various divisions and offices, centers, really centering that in a dedicated Center for Global Health, I think really sent an important signal to the NCI itself, as well as to many external partners, about a real increase in the NCI's interest and investment in this area. So for the NCI itself, I think, over the last decade, there's been a real acceleration of both the number of projects that have been funded, or that through the extramural part of the NCI that is funding work that is specifically going on in low and middle income countries. And again, I'll detail some of that on Friday, as well as the intramural program. So this is now NCI investigators who work within the NCI. Again, there's a pretty remarkable scale of international activity that is being conducted. And again, I think the creation of the Center for Global Health was not, the sole factor in accelerating that development, but certainly did play a role. The other thing that has been very important, I think, in the creation of the Center for Global Health is accelerating activities at the cancer centers, the NCI designated cancer centers. So one of the major accomplishments of the National Cancer Act in 1971 was to accelerate the cancer center programs, such that there are now 71 NCI designated cancer centers across the United States. And this was really an effort to identify centers that had a sufficient portfolio, capacity, expertise in transdisciplinary cancer research, and then to anoint them as cancer centers. And I think the beauty of this is that when centers are able to compete for this NCI designation, it really allows the NCI to make concentrated investments, and then allows these centers to leverage that recognition for substantial fundraising otherwise, through philanthropy, through industry, and through many other sources. So we, unequivocally regard at the NCI the cancer centers as being really one of the hallmark achievements of the 1971 National Cancer Act, and something that we will be celebrating next year. Creating the Center for Global, the cancer centers often, in addition to getting their core funding from the NCI, also take their lead to some extent from the NCI in terms of what it is interested in. And so, again, I think the creation of the Center for Global Health in 2011 really indicated to the cancer center community that this is something that the NCI is substantively interested in, that it intends to invest in. And we have worked with the cancer centers over the last decade to both try to stimulate global oncology activities that are occurring at the cancer centers by providing supplement funding opportunities to them to engage with LMIC collaborators. And then we've also worked with the cancer centers to map the scale and the breadth of global oncology activities that are occurring at the cancer centers. We most recently surveyed the cancer centers in 2018, 2019, and are planning for next year's surveys. But what is clear is that there's been this remarkable growth of global oncology activities at the cancer centers, such that approximately half of cancer centers now have a formal global oncology program. Many of them have substantive training activities that include young investigators, both from the US and from their LMIC partner institutions who are interested in global cancer research. And we've really sought to both document that growth and also to incentivize it. I recently had a chance to review the results of our most recent survey round with the cancer center directors themselves at the annual Cancer Center Directors meeting this summer. And again, I think they were really pleased to see how much their cancer centers were contributing. And many of them have reached out to me to speak about specific global oncology programs at their institutions following that presentation. And certainly, I was based at a cancer center before coming to the NCI, and I think this became very clear to me as our global oncology activities grew over the last decade, that this was increasingly a real signature program for our cancer center that distinguished it. And we were starting to kind of highlight it, invest in it, similar to our immunotherapy programs, similar to our cell therapy programs, similar to our genomics programs. And it was also increasingly attracting young trainees, postdoctoral fellows, PhD students, young faculty who were really being attracted to and recruited to our institution primarily because of their interest in wanting to develop global cancer research careers, largely based at the program that I led before coming to the NCI. So again, I think that has been a really remarkable kind of outcome, I think, of some, kind of catalytic NCI investments over the last decade, and something that we're really thinking a lot about how to continue to take advantage and optimize sort of the impact of these sorts of investments and of the cancer center's global activities specifically. Finally, I think I think this creation of the Center for Global Health was really important for the NCI itself. I think it was really important for the cancer center community. And I think it, has been really important for many of our partners, for example, professional societies like, ASCO, AACR, Aortic. Again, I think the signal from the NCI that this was something that we were substantively interested in has really opened up the opportunity to partner with organizations around the world. ASTRO, for example, which is the largest professional society for radiation oncologists, recently had their annual meeting. I think for the first time, the overall theme of the annual meeting was focused on global health, and myself and Doug Lowy had an opportunity to present at their presidential symposium. And again, I think that is another sort of discipline that really has an interest in engaging internationally, maybe hasn't done it as much as as medical oncology or surgical oncology, but are really looking to, I think, engage in a much more substantive way. So, I think that, in brief, and again, I'll try to review some of this with slides and in a little bit more detail on Friday. But I think, over the last decade, again, not that the creation of a dedicated Center for Global Health at the NCI was the sole contributor to this, but I really do think it helped catalyze many of the developments that I've described. And I think for us, what exists now is a really fairly robust network and a lot of foundational capacity building that has occurred. And, again, what we're really excited about is now in the next decade, really trying to leverage that for impact, and impact largely measured as, science that improves people's lives in LMICs, and then, helping LMIC investigators develop cancer research careers. So I'll stop there. I'm happy to answer any questions, or I know we have some time for discussion at the end. So.
Thank you very much, Satish. I mean, I suppose you're saying the Centre for Global Health, 10 years old, and during that time, you've clearly sort of stimulated and incentivized work across the US. And I suppose one sign of success is when you're describing the ASTRO annual meeting where global health is featuring at the heart of it. That is a clear sign of how much progress you've made in those 10 years. So thank you very much. And so Satish gave up his Sunday morning to speak to us, and our next speaker is giving up her Sunday evening to speak to us. And it's a great pleasure to invite Pavna Sirohi from Chennai to give her perspective. And I think we're into day 2 of Diwali, aren't we, Pavna? So whatever the greeting is during this time, may we wish that to you. And we're very much looking forward to hearing your words of wisdom. Thank you.
Thank you, Richard. Richard C. It's a pleasure to be here. And yes, it is day 2 of Diwali, but the crackers are still sounding outside. So I must congratulate you, Mark, Annie, and Susie for setting this up, and hearing Callie say that the aim hopefully would be to increase overall survival in low and middle income group countries. I think it's a tall aim and order, but that's what we are here for, to improve outcomes for everybody across the globe so that everybody gets affordable and equitable care. I've had the privilege of working in the NHS for a long time. Universal health coverage, yes, it has its challenges, but it's fantastic. And I've also had the privilege of working in a public system at the Tata Hospital in India and setting up cancer centers for Tata Hospital, and then also working in corporate India and setting up cancer centers for the corporate centers as well. And I'm just going to give you a low and middle income group perspective, mainly relating to India, but it very likely applies to most of the LMICs. And I had the privilege of going to Kenya, working in Kenya through Susie and the British Council and the Royal College of Physicians as well. Despite accounting for 62%, I think you'll hear about this throughout the week, and Richard and Satish have set a wonderful tone. Despite 62% of global cancer mortality, very little funding actually is directed to low and middle income group countries. And within India, there are huge disparities of care. You have centers of excellence like Tata Hospital, AIIMS, and quite a few private centers as well. But you have huge disparities of outcomes as well. Like in Northeast India, if we look at this study from the hospital-based cancer registries, the 5-year survival could be anything from 70% to 20% in Northeast of India. We know in UK and in high-income group countries, it's touching 85 to 90% based on the Concord data. So just briefly as to why the incidence of cancer is increasing in LMICs as well. Yes, there is an increasing population, but the population matrix is also very young. So we are seeing quite a few younger patients with common cancers. There is an aging population as well. Life expectancy has got better. So there is increased incidence and increased prevalence of cancer in LMICs. There has been a reduction in competing causes from diarrhea, tuberculosis, malaria, etc. Also, what we are seeing in urban India is, or in other LMICs, is infection-related cancers have been replaced by lifestyle-related cancers. Like the cervical cancer incidence has gone down, though the breast cancer incidence has gone up. Similarly, stomach cancer incidence is going down, but the colon cancer incidence is going up. Also, there is opportunistic screening in revenue-driven models as well, and raised awareness. There has been a huge change in social and cultural practices with higher education, office work, later marriages, fewer children, and there is a huge energy imbalance in India. So I've also had the privilege of working in rural India, where I worked with the ground workers like ASHA and Anganwadi workers. I've trained them, worked with them in early signs of cancer, and also worked in the cities as well. The incidence of cancer in rural India is very low. And I think we need to learn from that and see why that is low. And I think if we can find out why, we know some of the reasons why, then I think we can apply those to prevent cancers, not only in India, but globally as well. Just I'm going to do a quick SWOT analysis about London Global Cancer Week. I think you will hear this throughout the week. The strengths are, there are some fantastic Indo-UK networks which are already established, like the DBT, that's Department of Biotechnology, and CR UK collaboration. A lot of funding has gone in to promote research in India, along with twinning with UK. We have ongoing MRC trials in a few centers in India. Also, we have fantastic collaborative groups like the National Cancer Grid. You'll hear about the Credo workshop, which is done annually, the Indian Council of Medical Research, Indian Oncology Society group, and you have the 3 radiation, surgical, and medical oncology national societies, which are now working together and driving things to come up with guidelines and driving research as well. The challenges for us remain in, I think it applies everywhere, is in setting benchmarks. We do have a population-based registry in India, but it covers 10% of the Indian population. So I think we need to identify what our problems are so that the intervention could be directed at the number of cancers, or depending on the incidence of cancers, or the preventive strategies could be directed to that. So I think it's very important that we set benchmarks for diagnosis, prevention, and outcomes as well. Focusing on early diagnosis and building on diagnostic capacity, I think, is the key for us. There is, like I said, huge diversity in cancer care, and that is also related to topographical, geographical challenges that are there in Northeast India. That's why a lot of patients from Northeast and North India, you would see, would flock to Maharashtra, but very few from South India would go there because the number of cancer centers is more. Transparency in key outcome measures. I think if we don't know what our survival is, we won't be able to improve upon it. I think it's very important. I talked about this a long while ago. We need to publish our 1-year, 5-year survival data, not just from centers of excellence, but from every center, every cancer center that is labeled as a cancer center. We don't have, of course, the challenges, no universal health coverage, and funding remains a challenge. But again, this leads to huge opportunities in encouraging education, training, and research, which hopefully we will be able to do in a collaborative effort with UK. Driving sensible spending and choosing wisely. Again, this is an effort we've been doing with eCancer, and I think this is a meeting which we do once a year. We want to do this every year because, again, in revenue-driven models, it's, for example, immunotherapy has to be given or taken. And again, we need to have some sort of 30-day outcome measures post chemotherapy or immunotherapy. So we need to improve and deliver on outcomes. And again, huge opportunities in driving clinical nurse specialists, oncology nursing, and oncology pharmacy. And it's a pleasure to see, Annie, you're part of the group. The story started with Susie. I think Susie brings her family into most of the meetings. I do the same with my family. I take them to the villages for screening, clinical screening as well. So the story started in 2016, 17, and in 20. It's a pleasure to see this London Global Cancer Week come to fruition with key stakeholders from all across the globe. And congrats to everybody, especially Susie. Thank you.
Thank you very much, Papna. And, you clearly identified issues which actually are relevant across the world, aren't they? The increasing incidence of cancer, and interestingly, the variation between urban and rural communities in that regard. and you're stressing on the importance of measuring clinical outcomes in these settings. So we have a platform on which to start. So that has been a very helpful perspective from around the world. And maybe I could hand over to Annie just to deal with any questions or comments, and do feel free to come in with any comments or questions about what you've heard so far. So can I hand over to Annie? Thank you.
Thanks, Richard. Thanks to the panelists, both for the support and for the ideas of taking the UK Global Cancer Network forward. A few questions coming in, and we got some beforehand as well. So one from Nikki Morris saying, what about the diversity in the steering group? And I can just say, well, the gender's okay, but very important point, Nikki. And really these 4 people are just kick-starting the group, but underneath that is the founding members, and we will make sure and ensure diversity in the group, which is much better in the founding members. Questions maybe for the 3 of you. Should a network, this question came in earlier, should a network use service users? I mean, is that, you know, even for founding members, should we have service users? And I'm talking about maybe patients or other groups. What do you think? Can I ask Richard first?
A very short answer, and the answer is yes. I mean, there are some fantastic also international groups. I mean, we haven't mentioned really palliative care today, but take palliative care, for example, some absolutely wonderful palliative care groups in India, Pallium India, for example, the African Palliative Care Network, and also in the UK as well, because I think, you know, it's absolutely crucial. I think one of the things we've always dichotomized is that patients aren't part of the global scene, but actually building up domestic support for global oncology, it's really essential to get domestic UK patients on board with this as well, because they can act as fantastic advocates.
Thank you. Satish, same answer from you, from the NCI?
Yeah, I totally agree. So,
yeah. Pavna?
Same. I mean, completely endorse what Richard is saying, completely.
So that came from one of our founding members as well. So Ken Fleming is asking, are we both interested in service delivery and biomedical research? Are both or just one of these? Maybe ask Richard Cowan about that one.
Yeah, thanks, Annie. I mean, absolutely, we are involved in both. It's very important that we embrace research opportunities in addition to every way in which we can support clinical services. And as we all know, in clinical medicine in the UK, research and service go hand in hand, and we should use the same principles here as we are very familiar with.
Okay, thanks, Ken, and thanks, Richard. So one of the questions came from the founding members beforehand about advocacy in a greater sense, not just patient advocacy or patient and caregiver advocacy. And I think, Satish, you touched on this with the trainees and the opportunities for youngsters. How do we go about that in the UK Global Cancer Network? Satish, would you like to start, and then everybody, the other panelists, can chip in?
Yeah, you know, I think if there are structures, I think this is, you know, we live in a global world. I think we're living through a pandemic that, to me, is hopefully both, you know, highlighting the opportunities that exist in global health and also the importance, the general importance and interconnectedness of all of us. So again, obviously we need to get COVID under control, but my hope is that we'll emerge from that in a place of, you know, heightened re-emphasis on global health in general. You know, I think this is an area that a lot of young trainees are interested in, and to some extent you know, if you create viable structures by which they can do work that is meaningful to them and develop careers, I think it will sort of happen organically. Certainly, again, before coming to the NCI, I kind of led a applied global cancer research laboratory in Malawi, and once we had structures in place where Malawian investigators could come and identify areas of interest, and we could help them, compete for some pilot funding and help them with the kind of collection, the conduct of their studies and the collection of analyses of data. And, I had many deans at the kind of Malawi College of Medicine who would come to me and say, we never thought about sending our brightest young people to cancer research careers, but, that's increasingly possible. So I do think, and even for clinical investigators, for I think in many, at least in African contexts, becoming trained as an oncologist or pathologist or a cancer surgeon, often that requires this heroic effort over many years to travel outside your country. Many of them had opportunities elsewhere and chose to come back to their home countries to work because they wanted to contribute to the betterment of services there. I think often they want to contribute clinically, but I think it's frustrating when they don't have opportunities to ask and answer basic questions that are occurring on a daily basis. And so, I think the stagnation that can result when they're not given sort of academic career development outlets is a real threat to their kind of careers and the sustainability of those careers, and often leads to people getting burnt out and leaving and traveling elsewhere. So I do think there's clearly a pool of talent that will avail itself of opportunities when these are made, when these exist, I guess.
And one question just related to that is from Jeko Thatchell, just saying we have to highlight the importance of training the trainers as well. Yeah. Pavma, advocacy in its greatest sense with all kind of levels of folk and encouraging the youngsters, really?
So I think the only positive thing that has come out of COVID is kind of democratizing education and training. So, when we had to have people come over for sessions to places like Tata Hospital, AIMS, we are able to now do this over Zoom. So I do a Saturday evening teaching for registrars all over India. Started with 5 for the ones who were training with me, and now we have a group of 200 registrars from all over. So, and people from UK, London join in as well. So I think that's the one great thing. And the other thing is for patient empowerment, patient advocacy, again, is something we are very passionate about. We've started this breast support group meetings 3rd Mondays of the month. And it's become global now, with people from some ladies from Africa, China, Tanzania, from India, all over India joining in as well. So I think this is the only good thing that's come out of COVID, is that that we are able to connect with so many people. And I don't think we're going to give this up. This is going to continue. But in low and middle income group countries per se, there is lots more that needs to be done for patient advocacy and patient empowerment. Because I think in breast cancer, it's quite known that the ladies are quite vocal, but for other cancers like cervical cancer, head and neck cancer, it usually affects people from the lower socioeconomic strata. So I think there's lots more work that needs to be done there.
Thank you. And Richard, you would agree with that, yeah?
Yeah, absolutely. And I think also, we've learned, and just to pick up what Bhavna was saying there, I mean, one of the master classes in COVID-19 and cancer in terms of webinars and education was led by the National Cancer Grid of India. And it was extraordinary. They were light years ahead of anybody else in any other country in terms of the educational offerings they put on. So I think it's been fantastic to see this and to see it growing. And also the advocacy within the wider global health communities, I think it's going to be essential. I think we've dichotomized women's health before into, reproductive and maternal on one side and cancer on the other. And we've all signed up to the elimination of cervical cancer now. We're going to have to integrate women's health, but that's going to require advocacy and engagement across these generic domains. And I noticed Tim Eden's on as well. Hello, Tim, nice to see you. Same goes for childhood cancers. I would argue, children as well. We've been too focused supremely, and I understand why, on vaccination of children with DTP infectious diseases, but childhood cancers is increasing a problem in many places for apex centres. So the advocacy across the board is going to be essential.
So that also answers Tim's question about inclusion of pediatric and adolescents and young adults as well. And so I think for the network, Richard, Mark, and Susie, that's a yes for sure. But also to remember parents in that advocacy as well as everything. So we are going to include children and young people, and we know, Tim, you've got great networks there, and collaborating with your networks would be fantastic. Okay, some more that have come up just now. How do we make best use? This is from Emma Foreman, and I'm not going to answer this. How can we make best use of the full multidisciplinary team in these projects and make the most of our pharmacists, nurses, etc., allied health professionals? So how are we going to do that? Susie?
Thank you, Emma, for the question. I mean, yeah, I think that goes without saying that all the work that comes out of this network should be multidisciplinary, because this is the way that we practice cancer medicine. And so yeah, that's a big yes from me, Emma.
And Emma, are you a pharmacist?
Yes, she is.
Thank you for that question. So we've got Headley Glencross. I'm not only a professional, but a 30-year survivor too. So there you are in our meeting, in our audience today. So survivors, very, very important. So what about, where do we start? Do we start in the world? I'm asking, so Satish, where do we start with a network? Do we choose one place in the world, or does that come naturally? How do we start geographically?
Yeah, so I can't tell you how to run your network, clearly. I think what we have found, and I'll speak to, kind of the work I did at a cancer center before coming to the NCI, and also the way we tend to think about this at the NCI. We usually like to do things in, kind of focused, discrete steps and then build from there. Whether that's a geographic focus or a scientific focus, or, that can be, but it is obviously a huge problem that touches on many different areas, and it can be hard, especially as you're starting out, I think, to kind of try to tackle it all at once. So, having, some kind of thematic focus areas that would then, allow you to expand as you achieve success in certain areas. This speaks to the multidisciplinary, in the work that we did before I came to the NCI, we often, we started largely working on HIV-associated malignancies. They were high burden tumors. We largely were able to address them as medical oncologists and pathologists. Then we expanded into breast cancer and esophageal cancer, where we had to recruit surgeons and other radiation oncologists to our efforts. So we had a long view from the outset, but we tried to parcel it up into manageable steps where we could demonstrate productivity and build, because I think that was important for us. So,
and going along with the networks that you all cited in your presentations, really. So maybe that's it, the collaboration with the network, and see where it takes us. Pavna, any tips?
I think we need to just focus on things which things that are important to LMICs will be applicable globally. So we need to drive research and studies which have cost effectiveness models, quality of life, have outcome measures which are relevant to patients like overall survival, and look at how we decrease financial toxicity. We have to drive these kind of research. A patient I saw in the clinic had already spent 150,000 rupees before they came to see me on various tests that had been done in the primary sector. So I think there's lots that needs to be done. What I would feel is that we should just focus on one area, one city, one place, and deliver on that, and then replicate it elsewhere.
Okay, Richard, anything to add? You are a founding member of the UK Global Cancer Network.
Yes. I would say it's, to be honest with you, for me, it's always been about what's been important for our partners. If they've said, look, this is our local context, this is what we need to do here. I think the challenge has been reverse engineering that into the funders in the UK. And let's be blunt about this, many of the funders in the UK have very, very fossilized ways of thinking about funding research. And I think maybe one of the things the network can consider is how we advocate for our funders to be more flexible in the way the money is given, and the breadth of the domains to which this kind of research money goes, because that's crucial to actually be able to fit the real need and the real context with our partners across the world, frankly. And I think it has to be driven by them.
Okay, which brings us nicely on to our next two talks, really. One about our prioritised programme for comment from all our audience today, and then for the big one, which Richard's just mentioned, which is funding. So Richard, can we have some slides on the prioritised programme for comment? Thank you so much for your answers to the question. The discussion is always the best bit, I think. Richard, I'm handing over to you. You're on mute. Oh.
Thank you very much, Annie. And maybe just before we leave that section, I just wanted to return to the diversity question, because I think it is crucial. And I suppose one thing we are all aware of, we all work with colleagues from many parts of the world, and we also mainly come from cities which have very international population and a diaspora. And my experience, and I'm sure that of others, has been when we have approached our colleagues and the diaspora within our cities, there's huge enthusiasm for this. So although we have just sort of got the race started, so to speak, there'll be no question that we will have an influx of people from all parts of the world, hopefully, joining our network and making a very valuable contribution. So I think it's just very important to say. So we've sort of set the scene. We've said that the UK Global Cancer Network is a good idea, and we have heard the perspectives from around the world of the ways in which we should go forward. And I think what we'd like to devote a bit of time now in the meeting is to say, right, what are we going to do, and what should we be doing first as this network? And again, I'm very grateful to our founders who have contributed to drawing up, first of all, these 5 points, which I'll briefly go through. But the purpose of this meeting really is to air the thoughts. These are simply the thoughts that we have come up with initially. Nothing is set in tablets of stone, and part of the benefit of today's meeting is to hear people's ideas, and please do feel free to challenge what we put up here or add new ideas. But just to take us through that, we've got a mapping exercise, a membership database, collaboration, advocacy, and funding. And so just to start with, to conduct a mapping exercise, so we have said that we know there's a lot going on by our colleagues across the UK. And if you asked any of us at the moment, what is it? We haven't got a picture, and we certainly haven't got an idea. So if we can bring those projects together, we not only can help our strategy in the years ahead, but we also learn from each other. And so I think this mapping exercise is crucial, and Mark will return to this later in the meeting. The second is to establish a membership database containing details of individuals. And I think we all know that there are a number of individuals. There's a huge tapped resource in the UK of people who'd love to be involved in this sort of thing, but haven't got the vehicle by which to get involved. And one simple example at the Christie in Manchester, with our global health group, we sent out a questionnaire across the organisation, not just to clinical staff, but to our management staff, people in finance, portering, across the whole hospital, just with a series of questions gauging, first of all, did they think our hospital should be involved in this area? And secondly, would they like to be involved? And thirdly, what was their previous experience? And I think the take-home messages were that, first of all, there was a huge response from across the organisation, and people appeared that we had no idea had been involved in work in low middle income countries, which had gone unnoticed. And thirdly, there was a huge wave of enthusiasm that if there was an opportunity, they would be keen to be involved. So we feel that if we can, through the network, harness this sort of enthusiasm and the skill mix, we talked about the multidisciplinary team, that is crucial for delivery of all aspects of cancer care. And we would love to have membership from across the spectrum who would help us deliver what we want to do. So the third one was to explore potential collaborative projects. And again, I suppose we've talked a little bit about this already. There are all sorts of organisations, both within the UK, which Richard has alluded to, and internationally, which we've heard about. And I think if we are an identifiable group of people, it is easy for organisations both within the UK and internationally to reach out to us with suggestions, ideas and collaborations. And so we feel this would be a measure of our success if that we can establish ourselves, develop the credibility such that partners from around the world are keen to work with us. The next one, and we just talked about this in the conversation previously, about advocacy, and advocacy for obviously for our patients, and also advocacy for our colleagues. And it doesn't matter where you work in the health service or in research, it can be quite difficult to release yourself to be able to take on some of these roles. And I think if we can be a body with influence who can, first of all, show signpost ways by which people can take time or give their time for these projects, but also be a force within colleges, within institutions, within our hospitals, within Health Education England, within all these bodies, to highlight the importance for the staff to be able to do this. It does enhance their professional development without any question. And as we all know, within the NHS or within a research environment, experience such as this brings so much richness back to your host organization. And if we can get our act in order, if we can bring together a very strong faculty, if we can start working well together, then there's nothing to stop us starting to go out to funding sources and with projects which would come under the UK Global Cancer Network umbrella. And I think if we can, that's not something which we can do in the first 6 months of the first year, but I think looking beyond that, as we establish ourselves, another mark of our success was when we get that first grant in under this umbrella. Finally, there was, and this sort of links in with the other areas, scoping exercises seeking similar initiatives in other countries. And we've heard from our two speakers today of what is going on there. They've been good enough to give their time to join us today. And hopefully this will be the start of us looking at initiatives which are being done around the world, learning from them and sharing our experience with that. So those were the key priorities that we believed were a good starting point. And I suppose the question we want to throw out to the meeting now is, are these the correct priorities? And is there some form of prioritization in terms of what should be done simultaneously, what should be done sequentially, and what could be possible in the first 2 years? And it goes back to credibility, really. It is very important that we do choose some projects which will deliver within the first 1 or 2 years. We have been met with great enthusiasm with this idea and the concept, but I think we all know that unless there's something material showing benefit in the first 1 or 2 years, that credibility and the enthusiasm for the UK Global Cancer Network will wane. So I think getting the, what you might call lower hanging fruit, getting success early is very, very important. So I'll stop there, and shall we take some questions? And Annie, are you going to coordinate those as well, or am I?
So there are no questions. Maybe we could ask the folk to the audience to write on the chat line whether this looks like an okay way to start. Our priorities are there, or have we missed out anything vital really? So Satish has given us a flavour of how to do it and how to collaborate, and Richard collaborates all the time. Pavna, you do a lot in India, but you have the kind of experience of the UK as well. And there never has been a UK Global Cancer Network before. So first, this is a first for the UK. Priorities okay? I think if everybody's saying, if there's nothing on the chat, Richard, that's okay. I think that's agreement. I know the founder members, you know, they put these together, so I know that they will be agreeing with the priorities, because they did develop the priorities, and the rest of the audience seem to agree. So I think we could move on.
Pavna, was there something you wanted to add to that?
I just wanted to say that I think focusing on some of the cancers which are common to India, like gallbladder cancer, hepatocellular carcinoma. Gallbladder cancer is something which we don't see much in high-income countries, but we see in low and middle-income group countries. So I think when we prioritize research or questions which are directed at LMICs, we should also have that in mind as well, that cancers that are common to it. It may be something different in Africa. It would be cervical cancer.
Yes.
I think, or HIV associated cancers or other cancers. So I think we need to work with that as well.
In the regions, yes. What's important?
In the regions, yeah.
We have somebody from the audience, Nikki, saying it sounds great. I think the quick wins are really important, and a short, middle, and longer term vision is helpful, as we heard from our speakers today as well.
Yeah.
Can I just echo that, Annie? I think that what we're talking about is our initial steps, but we've got to have that vision in the longer term, and we recognize that we will evolve, and that different strands will come into the network, and we've got to keep a very broad horizon of the opportunities and the potential that we can do. And so we absolutely agree that we've got to be also setting ourselves 5 and 10-year targets once we're well underway.
Thank you. Okay, so Mark, you going to tell us about the mapping exercise?
Yeah, I'm just seeing if I can get my thing. There we go. Okay. And thank you. Right, slideshow, here we go. Thank you. First of all, I've got to begin by saying how grateful I am to Mishka Kira and Kalina Duncan from the NCI Centre for Global Health, and also to Lynn Davies at ICRP at Newport Gwent for their wise counsel and generous sharing of their expertise. And a lot of what I'll be saying about mapping actually will be coming from what I've learned at from their counsel. Now, it's been proposed that the network's first project should be the mapping of the current and planned links that exist in the field of cancer care between UK colleagues and colleagues in low and middle income countries. Clearly, let me just go back. Clearly, this will have a benefit, because first of all, it'll show areas where good work's already been done, but it'll also highlight countries and cancers that have been underserved and where there's a need for new projects. And Pavna was pointing this out, and it's been pointed out by other speakers as well. And at the same time, it'll identify potential active members for the network. But before we do this, if we're going to do this, then this exercise has to be systematic and comprehensive. We're certainly not short of places that we can go in the UK. There are plenty of different places where we can look for links. The relationship between the UK and the global south, for example, is long-standing, and many of our institutions have established links that will be relevant to us. But where we should go for links is not actually the most pressing question, and it's not the question the funders are going to be asking. These are the questions that the funders are going to be asking. I don't know if everyone can see. Can everyone see those questions? Oops, everyone see those questions?
Yes, they're fine, Mark.
Thanks. For example, what should be the scope of the mapping exercise? Should it include Ireland, for example? Are there recent links that are not current? And if so, how far back should we be going? Should we be asking, have you done anything in the last 5 years? What are our criteria for inclusion and exclusion? So our mapping exercise needs to be systematic throughout. We need to create a concept note that provides the answers to these questions and more. From that, we develop a protocol, which we send for external review to stakeholders. Based on the responses to the protocol, we conduct a survey and feed the data into a project database to which UK Global Cancer Network members will have real-time read-only access, which will be a benefit of their membership, so they can see how we're progressing. They won't have to wait for the year, 18 months it's going to take to do this exercise. Finally, we'll make a report, possibly with recommendations, and use the data we've collected to inform network projects. But from the get-go, we're going to have to signal that this is an exercise that will need to be repeated every 5 years. If I may, I'd like to turn to the parallel question of network membership. This touching on the question, should we have projects simultaneous or sequential? I think in this case, it will be simultaneous, two things be happening at the same time. We have proposed, with discussion with the founders, 4 membership levels. The active members are the core of the network, and the network's UK activities should revolve around them. We want to encourage linking up between committed individuals because that leads to new opportunities for productive collaboration and successful funding acquisition. Active members will have their own special password protected members area on the website where they can search for potential collaborators for their projects. They'll be asked to pay a minimal annual membership fee of £25. We'll also want to create a welcome space for institutional support. And I'm really glad to see Richard Sullivan's slide with all those many places that have already got skin in the game. We want them to contribute actively to initiatives that we are doing, and also that we should also be contributing to initiatives that are developing within institutional silos, as well as raise institutional awareness of the network. Awareness leads to recognition, it leads to endorsement, and it leads to support in kind, such as hosting meetings and webinars, sharing news feeds, and so on. Unrestricted funding by sponsors will be both welcome and necessary to support the network's administrative infrastructure. We'll also want sponsors to recognise the expertise of our members and to be aware of projects that network members might propose as a collective. Lastly, the work of the network and the active members will be of interest to other people and players, and we should endeavour to be as transparent as possible, as well as take the opportunity to inform and educate UK society about the realities of managing cancer in low and middle income countries, and also the value of engagement with other health systems. When they join, associate members will be invited to make a donation to support the network, but this won't be obligatory. The membership registration button is now live on the UK Global Cancer Network page, which is on the London Global Cancer Week website. Everybody attending this meeting is being sent the link for membership. We've designed an application form which we believe collects the minimal amount of personal data yielding the maximum value. Each applicant will be asked to place themselves in what they regard as the appropriate membership category. Their details will be entered on a register of members, which is held by the network. So let me just pause there and ask Annie, are there any questions or that have come in, or shall I proceed?
So no, I'll just stop there for a minute, and we would ask the audience for questions about both the mapping exercise and the membership. Just to go back for some questions, Richard Cowan, on the priorities, which came in a bit later. Good priorities, Tim Eden says, but it will take 2 years. I think you said that, Richard Cowan, 2 years to establish funding for a project. Yes, thank you for that. Heather Cubey said, I wonder if there's some synergy somewhere with the Scottish Global Health Collaborative. And it's not specifically cancer-based, but looking kind of out of the box to non-cancer-based collaboratives as well. And many interested healthcare providers are on the People's Register, a number of whom will have oncology interests in prevention through the continuum of cancer care, really. So Richard Cowan.
Yeah, I mean, thanks very much, Heather. I think this is very important. I suppose it goes to the point we're making, where once we have an identity, other organisations such as the Scottish Global Health Collaborative we can approach you and you can approach us. And I think it is vital that we are sort of seeing each other's strengths and perhaps finding areas of particular need which we both can work very closely together. And I suppose that goes on to an earlier question, I think from David Coleridge, which was saying that we've got to be careful that we don't duplicate what is already being done elsewhere. And I think there is always this danger that if we aren't aware of the other organisations and groups, particularly within the UK, their activities, there could be that danger of duplication. So yes, we want to be sufficiently prominent that these organisations will contact us, and part of our role is to go out to these organisations, such as the one you quoted there, Heather, to find areas of mutual interest where we can work together. Thank you.
Okay. Thank you. From Katie Piddock to the panelists, and that's through the chat line this time. It says the only priority maybe missing is an assessment of what partners from LMICs want and need. And I think Bhavna gave us a flavour of that. So she said you have to go out and you have to of course address the need in that area or that country. So Katie is working, she's planning a project with some colleagues from LMICs looking at addressing this, that may give this network some direction. So certainly to keep in touch, Katie. So she's keen to discuss that with us further, which is exactly what we're looking for today's inaugural meeting. So thank you for that, Katie. Engagement is key, says Pavna. Great.
Can I also raise the point here as part of one of the fruits, I think, of the mapping exercise is that we will engage inevitably with what I think, Andy, you referred to as the diaspora, working within research, working within clinical practice, and also working within the cancer community in this country. And we'll have very little excuse to be uninformed about the needs for what is needed in low middle income country settings. We'd really have to actually studiously ignore it. So I actually have no fear. I think we will uncover a treasury and wealth of stories and situations that we all say, gosh, we will ask where we start, and this is where we have to have some sort of discussion, some council, some annual general meeting where we actually say, right, this is where we're going. It can't be just the steering group, for example, and it won't be. We have to deal with governance issues, and that comes in the first year and a half. I would hope in the first year. So the mapping exercise is the first thing we do, and we will hear what we can hear.
And thanks, Katie, and we'll involve you in that, especially with the up-to-date mapping that you're doing as well. So thank you for that. Okay, Richard, Mark, rather, would you like to take us on to the biggie, which is not the admin structure, but the funding?
No, we have to do the admin structure first. You can't. You've got to eat your bread and butter before you have your jelly, you know. Okay.
Thank you.
So we've identified at least 6 areas where the network will require assistance and support. At the moment, it's just the 4 people on the steering group, but we are looking for people to come forward and say, I will help if I can. We're looking for development of the first project, obviously the mapping exercise. We need help with comms, managing the membership registration process, providing secretarial support for the steering group and organizing meetings, facilitating developments of agreed strategies, and finance. And until we secure infrastructure funding, we would appreciate offers to help with these tasks, as this will not only make progress quicker, but also make the network a genuinely collective initiative. And as we uncover more and more people in the mapping exercise, we hope that the body of the network will grow. So when it comes to finance, we've identified 5 potential sources of financial support. And we hope that with this discussion today, we may be able to add to this list. So if you have ideas or streams that aren't on there, then please use the chat line and we will take those on board. Securing funding for our sorts of needs, whether it's project funding or infrastructural support, generally requires proof of charitable status. And this might be something that the network considers applying for in the future. Each source, of course, will require its own strategy, but being a charity or having links with a charity, I think, has to help. At present, the UK Global Cancer Network, its status is as a product of London Global Cancer Week. Now, sponsorship funding for London Global Cancer Week is currently lodged with the Challenge Fund, which is a UK charity committed to improving the care of cancer patients in low and middle income countries. You see the Challenge Fund at the moment has 2 other projects, the African Cancer Registry Network and a new one building the first major palliative care centre outside Kathmandu, Hospice Nepal. This year, London Global Cancer Week has raised £23,500, of which £22,000 will be in its ring-fenced account within the Challenge Fund. I've spoken with Patricia Newland, the CEO of the Challenge Fund, and she's happy to let our association continue until the network makes a decision about how it wishes to go. And I'll leave it there because that is a discussion either for now or for some time, possibly an AGM in 12 months' time. I'd just say lastly that I hope that the UK Global Cancer Network, its main annual meeting, will be part of London Global Cancer Week, because then it will keep close to one of the routes from which it's sprung. Thank you very much. Back to you, Richard, I think.
Thank you very much, Mark. And I suppose one other just comment about the administrative structure.
Yeah.
You mentioned that we would hope to have our annual general meeting as part of London Global Cancer Week in 2021. And I think at that point, we hope that we will have reached sufficient maturity such that we will be able to develop a proper administrative structure. I mean, I think at the moment, the 4 of us are very happy to be the steering group, but we recognise that a much more formal administrative structure will be required. And I think we've setting ourselves and everybody in this meeting really 12 months to develop that. So are there any further questions or points or ideas that people would like to raise on the back of what Mark has just told us? And maybe it's an opportunity to thank Simon Middleton, who has been fantastically supportive in generating the website, I know for London Global Cancer Week, but has been working very hard in the last few days, helping us set this these details onto the website for membership. So Simon, on behalf of us all, thank you very much for doing all of that.
It's been a pleasure. Thanks for having me.
So the other thing, Mark, I suppose that we should say is that you put up the project. Well, I think we've sort of agreed the projects and where we're going to be going in the first 1 or 2 years, and you've sort of highlighted that we are looking for members who have got an interest in under any of those particular categories to come forward. And I suppose the question is, how do they come forward, Mark? What would you recommend people do if they would like to offer themselves under any of those particular categories you've mentioned?
Well, they could certainly contact me, but I think one of the things that there is an email address, londonglobalcancer@gmail.com. They can write to that, or they can write to me at mlodge@canet.org, or come through whoever people already know on the steering group, and we'll put this together. We'll be writing to everyone who's on the call, and that will provide an opportunity for them to reply, I think, and feedback. Well, I'd like to offer this, or I'd like to offer these suggestions, or come up with further questions that require a response. Would that be satisfactory?
Yeah, and Katie's just come up with another idea and another potential sponsor, Mark. Pharma and organizations running clinical trials. So clinical trials network, global clinical trials networks as well. I think Richard mentioned that, but pharma big time. And many pharma companies have philanthropic programs and foundations, as we know, and companies making radiotherapy machines, a big market for them to get involved in. Thank you, Katie.
Yeah. Thanks very much. I think, therefore, it might be an appropriate point in the agenda to hand over to Susie, who might just give us some review of the meeting. And I suppose, Susie, it's true to say that we will produce minutes, which we will circulate, and things like the contact details that Mark had mentioned would be available for everybody in that. But I'll hand over to you, Susie. Thanks very much.
Thank you very much, Richard. Well, thank you everybody for coming. I would particularly like to thank, firstly, Richard Sullivan for showing his support and for highlighting how we should be doing this as a country, and for his wonderful quote that those who say it can't be done are usually interrupted by those doing it. I thought that was really brilliant and very encouraging. Thank you so much to Satish for giving up your valuable time at the weekend, for sharing with us your wealth of experience and the journey that the NCI has taken, which is really valuable for us to learn from. Thank you so much to Pavna for giving up your valuable time this weekend, especially during Diwali, and for just impressing on us how we need to keep this relevant to lower middle income countries. I'd just like to encourage everybody that's on the call to reach out to those who think might be interested in joining, those that are involved already, or those that they think might want to become involved. I think that during the course of this meeting, we've laid out what we are trying to achieve. That is to enhance our contribution to cancer care in low and middle income countries by bringing together in a multidisciplinary fashion people in the UK. And we've highlighted the potential benefits of this network and different ways to get involved. As Mark and Richard said, people on this call will be sent a link to the website, and we will be in contact with details about more meetings in the future. We really hope that everybody can come to as many of the events during London Global Cancer Week 2020 as they can. The website has details of all the meetings, and the vast majority of which are free to attend and are open to all. Thank you very much again for attending, and with that, I'd like to close the meeting. Thank you.
Thank you, Susie.
Thanks, Susie. Thanks very much.
So much, Susie. Thanks.
Thank you. Thank you, everyone. Bye-bye.
Bye-bye.
Thank you. Bye-bye.